So I think we have a bit of time for some discussions. May I start, maybe, Harry, by asking you, you suggested that HBs antigen lower than 100 units per milliliter is a good predictor of a response, HBs antigen loss. Now, does it matter whether you achieve that with a nucleotide analog or PEG interferon?
Well, the studies that I presented were basically to see whether you could get a sustained response on nucleoside analogs. Definitely with interferon you would get similar results. The cutoffs have not been well defined there for at the end of treatment. We know that during treatment S antigen levels for interferon are important, particularly to predict non-response and with a very high negative predictive value, and to predict response with a actually lower positive predictive value, around 50. But I'm not aware that the level of 200 is indicative for S antigen loss. It will definitely be indicative for sustained response. And yeah, and if you look at S antigen loss, that's what's almost an announcement, right? You're looking at the same parameter for a specific endpoint. So the answer is yes at the end of the day.
Tariq, are we at the point now where you routinely start people with combination therapy with PEG interferon and a nuke? Or how do you select those patients, and how are you doing it in your practice?
No, in practice, in the majority of cases, I use monotherapy as recommended by the guidelines, either interferon or analogs. But I start to consider about combination therapy, because if there's a good compliance, comprehension of the disease, and good all predictors of seroconversion for interferon, it means high transaminase is higher than threefold, and low DNA levels. And if the patient is young, he could be a good candidate for this combination. So I'm starting, but really, in the majority of cases, I follow the recommendation and the guidelines. So it's more research, but I think it will be interesting in the future.
Stefan?
On talbuvidine, and if you look at the improvement of GFR, 10–15%, in some studies 20 to 25%. This is by far better than whatever can be offered by our nephrologists. So I'm sitting with my transplant patients on calcineurin inhibitors without hepatitis B, and sometimes thinking whether I should give talbuvidine to those patients to improve kidney function. I wonder whether there have been any trials by nephrology, by combination with other drugs causing nephrotoxicity, whether talbuvidine can also improve kidney function in concomitant medications with completely different settings outside hepatitis B?
Yeah, this is a very interesting approach and idea, but I'm not aware of any data that anyone has ever used talbuvidine in non-chronic HBV patients. So I cannot tell you. No data, yeah. But it's interesting, but it should be the company, Novartis, to support this trial, because it's not how we can justify the use of this agent in non-HBV patients. I don't know.
Ira?
Harry, it's time for my annual question to you about what you do in your practice. You did address it as far as stopping therapy in E-negative patients who've had sustained or long-term viral suppression. If I understood you correctly, I think you're saying that you individualize it, you have a dialogue with the patient. When I sit with patients after 5 years of viral suppression who started as E-negative patients, the dialogue usually goes like this. I feel obliged to tell them the concept of stopping is out there. I tell them what I can about the data, and I try to elicit something from them, but invariably they say to me, you're the doctor, you decide what to do. And it sounds like you're doing that also, but you're not being proactive about stopping if they're not pushing you. So first of all, is that correct? And second, is it time that we can use HBsAg titers and interject that into the discussion, and perhaps feel more comfortable about stopping if the levels are less than a certain amount, like 100 IU?
Yeah, I mean, if someone really wants to stop treatment, I have that discussion. I don't proactively push them to stop unless they have S antigen loss. But I don't think the data are not convincing enough at all to stop treatment. And we're really in a phase of studies, basically, of doing this in the setting of research rather than into clinical practice, I would say. And obviously in some countries the guidelines are different, so they cannot continue with these nukes, and they have to stop. Regarding the S antigen level, I would have a similar answer, unfortunately, that we're getting more and more data on this, and there are now several studies which have shown that the S antigen level might be a good marker to predict the absence of relapse or to predict sustained response. But yet the data are limited and have not been confirmed. So I wouldn't say yet it is ready for clinical practice. It is unfortunate still that in a country like the US, S antigen quantification is not available for many doctors, because there's so many fields in hepatitis B where we're using this now, or we're about to use this. And with new treatments coming up, it will be even more important, I would say.
Maybe just one short comment. According to the cutoff, I think that the patients who have this very low level are very few. So on analogs, I think it's about the difference between an interferon analogs is the cutoff that change or has the same significance. I think the cutoff may avoid relapse, but there are few patients going to this. In clinical practice, sometimes the patient asks you, could I stop? I've been 5 years on treatment, he has no cirrhosis. And then in few patients, we can say this if we are confident about the follow-up, they are following measures to be sure that there's not a flare after. So in few candidates, we are starting this approach.
So Tarek, may I ask you another question regarding the combinations? You showed us basically that the duration of the combination was the most effective. The longer you treat, the better is the result, right? So is it really just the duration, or is it also about sequencing, like that you do first nucleotides, then interferon, first interferon, then nucleotides? Is there anything to be learned here as well?
Yes, excellent questions. I think there was a scientific rationale to say that could we first block the virus and then encourage the immune systems, and to make different strategy with the startings on analogs and then on interferon. So at least there are several trials. There's one trial also with the French NRS starting this strategy on patients who are already controlled with analog to start with interferon. So far, the results are not so convinced. So at this stage, I think that we don't know how to use it the best, and the different strategies do not provide answers.
I would agree to that. We just published a study in hepatology where we initiated with entecavir and then added on PEG interferon. But in any way, I would say combination of PEG interferon and nucleoside analog from a theoretical viewpoint seems to be very attractive. Yet, in all of the studies which have been done, the additional benefit is very, very limited. Even in the study that Tariq just presented, it's just a few % extra response, basically. So is that worth this combination? I'm not sure.
All right. So I think if there are no further questions, we will close the session. Thank you very much for the excellent presentations.